So now we have the opportunity to have a discussion, and I think it sets the stage. There are a lot of questions that I think will be answered, and hopefully we can answer some of your questions today. But I would encourage anyone, there are individuals in the audience with microphones. So if you have questions, please raise your hand, and out of respect for the rest of the audience, I'd like you to use the microphone so we can hear the question, and then we can put our panel on the spot. I have the easy job. I just get to forward the questions. Right over here. But as we're getting ready, I'd just like to say thank you. This was a tremendous discussion this morning and sets the stage for the rest of the summit. Zoe?
Thank you. Thank you for a series of wonderful and intriguing and inspiring talks. So my name is David Sonner. I'm a physician, bioscientist, and computational scientist, and I serve as the Vice President of Clinical Translation at Nido Biopharma and Medical Affairs. So my question for the group here, we heard a lot of excellent work on in biology in the clinic, but given the complexity and incomplete elucidation of the pathogenesis of IPF, I was wondering if you could comment on the use of systems biology and machine learning to identify biomarkers and better characterize the Byzantine network behind the disease. And if you do think it's important, then there are two sub-questions, one of which we can take offline. One of which, and I've got a book chapter that's forthcoming on AI and drug development, where I emphasize the importance of vibrant cross-disciplinary collaboration among bioscientists, clinicians, and computational scientists, which have sometimes worked in silos. And if you agree with that, please comment on it. And then lastly, and this might be more offline if it's more technical, comment on the most promising approaches in deep learning, mass action stoichiometric simulations, probabilistic graphical models, abstract declarative models, but that might be more offline. The first is, what's the role of systems biology and machine learning, and how important is cross-disciplinary collaboration?
So, for some reason, the members of the panel selected me to answer this question. So the answer is yes. Now, to move one step backwards. So, one is definitely so all of us, and again to the patients in the room, when we say AI, it's just a really good computerized method to learn things that the human brain cannot deal with, and it's a lot of strength in the data. So on all levels, computational, biologists, statisticians, scientists, physicians, this has to be a multidisciplinary team, and that's actually happening. I think the two cool things that I'm seeing now which is changing is some of the things that we discovered, 5-7 years now, we actually know that they're real. They represent the patient reality. The telomere findings, MAC5B, TOLIP, these things we don't have a doubt now about them. So that's a big deal. The second is the immersion of large cohorts. So like a study like Precision's, again, when I started my career, I published 5 IPF patients and 2 controls in a very high impact journal. So now we're speaking about a completely game changer, and we could implement these approaches. And again, in my research, one of the most exciting things has been the single cell resolution. Because what I feel moving from global analysis of tissue to single cell is like moving from a telescope in Arizona to the Hubble telescope. So instead of thinking there's 5 planets, there's now thousands of planets. Now, of course, all of us have to be very careful that, we don't need to necessarily see every single tree in the forest to understand the forest. But we actually can create now a model of fibrosis. I actually think, and we're working exactly on applying some deep learning approaches, on understanding what happens when these cells start changing. How do they change the homeostasis of the organ? And then try to predict, was it the impact in actually using some amazing initiatives in cancer, mostly the Broad Institute CMAP and other perturbogens things, to actually see, are there drugs in publicly available data sets that may be effective, so we don't need to invent new drugs. So this is done by deep learning and other approaches. And actually, we've shown a poster yesterday that showed exactly an effort to repurpose a drug based on computational analysis. In 2 years, we finished our preclinical assessment. It's going to a phase 2B in 2 months. Yeah. The other target that came out of my research at postdoc took 20 years to fail, right? So really exciting, and I completely agree. We need computational biology, we need systems biology, and we need them in the room here so they understand the vocabulary that they see our patients.
Just completely agree with Naftali. Anytime you use an agnostic approach, a wide approach like systems biology, casting a wide net for a disease that starts with the word idiopathic is the right thing to do. I mean, we're not smart enough to know what's really causing it and what's the best approach for every person. And so, yes, we definitely want to do that. You know, there's been just a wonderful juxtaposition of different fields, fibrosis and other organs, different types of scientific communities like senescence and cancer coming in and giving insights to this disease to help. That I think, you know, it's the interface there that will really spur new approaches and really novel insights and something like Precisions, but other cohort studies like it that just allows the scientific community to follow the data is the best thing for this disease.
So I'll just make one last comment about their approaches, right? Their tools. And the tools are, at the end of the day, only as good as the questions that we pose. And so a lot of that is about bringing the integration of the material back. And so your point earlier is, you know, what we're also seeing is a far greater integration from the mouse doctor to the clinician to be able to say, okay, what clinical data can we bring to bear? What question can we bring to bear that's going to use that systems biology approach to have more targeted answers?
Did we answer the multi-step question? Excellent. I might, I see him sitting there, so I'm going to ask Dr. Roman a question before he gets to ask his. The question was, should we focus on multi-disease states like fibrosis? I might expand that to fibrosis in the kidney, liver, skin, but also ask you, are there lessons learned across species?
I was going to ask a question. That's a good question. There's a lot of data that indicates that there are common pathways of fibrogenesis in multiple organs, but also that each organ is distinct and that multiple pathways are different and therefore interventions are predictably different. Animals, birds, and other species also develop pulmonary fibrosis, and we can learn from them as well. We haven't taken advantage of that opportunity. Veterinarians are all around the world trying to figure out how to deal with this, and we haven't converged the veterinarian communities with the human communities to advance this for both. So that's an important area. Let me ask a question which I think extends what you guys just started. We've heard, first of all, thank you for the presentations. We've heard this morning presentation about cancer, and we heard presentations about IPF. These presentations sort of suggested the similarities between the two and how we can use similar approaches to intervene. But they also tremendously emphasized to me the differences between the two. In cancer, you have a cell that transforms into a tumor, and we have identified genes that provide information about a pathway that is directly related to understanding tumor biology, and you can intervene in it. In fibrosis, on the other hand, Naftali just told me that there's a whole change and transformation in the organ. And we are getting faster and faster at identifying genes, but not at understanding pathways that relate to biology. So how do I translate that genetic massive information that you're generating into intervention quickly?
Yes, great question. Because as I continue to learn about pulmonary fibrosis, I started thinking about the similarities and these similarities. The similarity biologically is the complexity of each one of these diseases, and how unraveling the biology is the answer. And it's like a marathon. You have to start with one step, and then you go to the next one. You get to the next one until you achieve your goal. In oncology, it's actually the complexity of the disease in terms of molecular alterations that you are encountering in pulmonary fibrosis, the issue that is most complicated for us to decide on treatments. Because there are few cancers that are driven by one alteration. It just doesn't happen. It happens actually only in one disease, which is chronic myelogenous leukemia, where there's one abnormality, and then it was figured out, the therapy for that abnormality. So for us, it's the same thing. What are the cells involved? What are the alterations that really drive disease behavior versus alterations that just happen to be there, as I mentioned, passenger alterations. And it's not only mutations, but gene copy number, what happens from the genes to the RNA, what's happening with epigenetic alterations, what's happening with the protein, what's happening with the environment that we all live in, and how those exposures alter gene expression to help us understand what are the pathways that are really relevant and how can we utilize that information to develop combinatorial therapies. So I can tell you, in spite of the complexity, it's just starting one place, and I think you guys are there. I think the knowledge of biology is really expanding significantly, and when you have the pieces of the puzzle, then you'll be able to put the puzzle together.
When I was listening to Dr. Perez's talk, I was actually very inspired. Not exactly the way I usually think, because my mind tends to wander off when I listen. And I would say, one is, yes, you gave us the road to treating, the focus on patient-relevant biomarkers that are integrated within the clinical research. And we're starting to do it. It took us a while, but this is one important thing. The other thing I'm going to say is, our community has to change in a way that cancer has changed many years ago, which is recognition of the urgency and terrible nature of the disease. So in our field, if we give a patient a drug and they get a little bit of a rash, that's it. We get afraid. We don't want to treat a patient with pulmonary fibrosis that's a lethal disease with a drug that may have a minor side effect. When I look at the cancer field, my medical intensive care unit now is full with patients with side effects of the new amazing checkpoint inhibitors. But the cool thing is, we understand the side effects, we take care of it, the patients have gotten treatment and they go back and they're alive and we're progressing. So I think that we need a paradigm shift in the way we think about our disease. And really, the drugs that are going to be effective, I hate to say that, are also going to be dangerous, And there has to be a change in the way we think about these things. We need to aim to prolong life, to make people feel better, but we need also to understand that there's going to be side effects and risks, and we cannot stop at the first sign. We have to come over the trauma of azathioprine and Imuran to find better drugs.
So Jesse, I want to answer you a little more directly, right? Because really the swath of the question was, we ended up with some pretty fancy tools to look at underlying genetics by genome-wide approaches. And the truth is that they haven't really moved the field forward anywhere near as rapidly as we thought it would. Mostly because we found a lot of genes that were not necessarily in regions that we understood how they function, or at least what their relationship was to function. And I would argue that we've gotten better at this moving forward, and particularly in the field of pulmonary fibrosis, we need to continue as we search for truth to look at it from multiple directions. So, newer approaches using bottom-up, approaches from systems biology, looking at proteomics and transcriptomics to select which genes, and then which, one of the things that I think we did intelligently in our interaction study was take a look at variants that we knew up front would affect product. We didn't look at all of them, we looked at 5. And so by, research, of course, is looking where the light is, right? We take a look where we can see, recognizing that I don't yet know what the intergenic regions do. I believe they do something, right? But focusing on where we can focus and then looking for truth in with multiple pieces of evidence. I think that's as Dr. Perez just said, you put one foot forward, you keep adding pieces of evidence together, and you try to put the puzzle pieces together.
Jesse, great question. And I just want to add a couple of comments in that we have identified relevant pathways. The genetics that I presented is telomere biology. We wouldn't understand what we know if there hadn't been the basic science on telomerase and telomere biology. However, telomere shortening leads to senescence, which is evolutionary constricted because it's a pathway that protects humans against cancer later on in an older age. I mean, there's 2 major tumor suppressor pathways that puts the brake on senescence. And so it's complex because we're dealing with an age-associated disease where there's built-in inherent breakpoints against very crucial pathways of senescence and cancer. And I think that's where it's tough. It's really tough because if we're going to have relevant therapies, yes, they may be dangerous, but I'm certainly not going to subject patients to therapies that make them worse than the underlying disease. Okay, that's unacceptable. We need to have better therapies. We need to have more effective therapies, and we should never tolerate therapies that make a patient feel worse. So, I think it's going to be tough because we're dealing with the inherent biology of older onset disease and the complexities of senescence in the IPF.
We have an audience question.
Hi, this is a question for Dr. Garcia. This is a question for Dr. Garcia. Several years ago in the New England Journal, there was an article that showed that the androgenic steroid danazol increased telomere length. Is there a clinical indication for danazol as yet, or is it still experimental?
Great question. So danazol was treated basically for patients with dyskeratosis, with those with the rare variant. So that's the pediatric form of very severe telomere shortening prototype. I had one of the patients that was enrolled in that trial. There was tremendous side effects that limited the effectiveness of danazol long term. And so I think it has to be studied in greater detail, but there was a very significant side effect profile that would interfere with, I think, treating most patients. That said, I think therapies that may increase telomerase expression or activity minimally, but not drive it to cancer, may be potential avenues to think about. And I know a lot of drug companies are scared about that approach, but patients with these driver TERT promoter mutations, we showed at least one person who had the acquisition of that somatic mutation for 10 years without having any evidence of blood cancers, suggests that in the context of telomerase dysfunction, telomere shortening, et cetera, it just increasing it enough may be sufficient. And I think those are things that need to be studied. I mean, I think that's something, again, a big area that can be studied.
Great. Just one more comment about the telomere, and again, as a sort of a little bit of not an expert on telomere biology. What I got excited is actually the different cell types may be affected differently by telomere shortening. So I think instead of sort of the sense of doom, that's it, the main thing is we can now target these specific cells that express the accelerated senescence that is due to the telomere shortening and understand better. So that's one thing. And the other thing, which was beautifully shown by Christine and others, is the fact that by recognizing telomere shortening, you can avoid side effects of therapies that hurt some of the cells. So I would probably focus more on the cell-specific therapies and the downstream mechanisms. But the one thing I want to say is never do something that may shorten your telomeres. So make sure, relax, sleep a lot, don't forget you're sleeping. If you have sleep disordered breathing, take your CPAP. This is important.
And don't smoke.
Yes.
And yes, could you introduce yourself so the crowd knows who you are?
Yeah, Steve Berger, a patient. And I'd like to actually follow on that comment. It sounds like there's a lot of focus in the research on the drug impact on progression, and particularly dealing with the ergodic issue of not doing research on mixed populations. I'm just wondering, is there a need for a complementary focus on lifestyle impacts, and particularly air quality? Could we have groups of patients who are maybe impacted disproportionately in their progression due to air quality issues that we're not identifying or other lifestyle issues?
I'll start. To borrow from Naftali, yes, absolutely. Two comments. So we know that it's normal. We live on the planet. It's normal for us to inhale, right? It's normal for us to therefore have some measure of injury in the lung. And at least my theory on this is that it's the repair side of the exercise that's a little screwed up, right? But if you can minimize the injury, then if the repair is screwed up, it's less impactful in terms of the downstream. And I continue to tease, it's great that we have these new antifibrotics, but actually treating the comorbidities, as Naftali was commenting on, and there's a long list, are probably even more impactful, right? We lose sight sometimes, and that's why I show that Panther data and give you that hazard ratio of 9. I still think we're surviving more as a group because we're not giving prednisone and azathioprine, right? And so it's about doing the right thing, right? And so things like reflux probably have a significant role. Certainly smoking cessation has a role. Treating sleep apnea, sleep disordered breathing has a role. Cardiovascular disease is known to be 4-fold higher, right? You're 4 times more likely to have coronary disease. Heck, we got a lot of good treatments for that, right? And so a bunch of these things, we have established therapies that will make patients live longer and perhaps more importantly, feel better.
I might comment on that. As physicians, we treat patients, not organs. So that means we have to be comprehensive in how we care for individuals, not simply the disease. And I think that's part of your point, helping to understand prevention by reducing exposures such as air pollution, tobacco smoke, but also make sure that the comprehensive evaluation to treat all aspects of your health is fundamentally important, including nutrition. Naftali mentioned we rarely address this, but the psychological aspects of disease. It is quite clear that if you address them in a meaningful way in anyone with chronic disease, the outcomes are significantly better. And so I think it's an excellent point that you bring up. One question that I had, and I'll direct it at Christine Garcia, because I know Janet Talbert isn't here yet. She's at the genetic counseling meeting, but I imagine patients in the audience watching this presentation, you would be excited. But the question that probably isn't being asked is, Christine, if I have pulmonary fibrosis, should I get genetic testing? You advocate with elegant work from your group, from Dr. Newton's group, the impact of the abnormality and its consequences. And so it is a challenging question, but I can't think of anyone better adept to answer it.
Okay, so I get asked this question quite a bit. And right now I would like to pose it in terms of the bigger answer is we still need to do more research. We need studies like Precisions and others to really understand what is the benefit across the board, okay? But we do know already that if you have a family history of pulmonary fibrosis, if you have a family history of having clinical features that are consistent with a short telomere syndrome or suggestive of a surfactant mutation, we know that the pre-test probability of finding something with a genetic test is relatively high. And so the advice I give my patients is in that particular subgroup, I definitely think the benefits outweighs the risk right now, and so we proceed with genetic testing. As you know, that this is a very complex issue. It's one that's weighed upon by the American College of Medical Genetics in terms of what can be returned and how those results are returned. And so it really becomes a dialogue between the genetic counselor, the physician, and the patient, one-on-one, because it has implications not only to that one person, but also the implications of where they inherited that variant and who the other people, if a variant is found, might have inherited it in the family. And so it becomes a very personal discussion, because we're not talking about cancer somatic mutations, we're talking about inherited mutations. So I would say that in that context, that's where the indication for those with sporadic or non-familial types of pulmonary fibrosis, it's an open research question about whether or not that test or a CLIA-certified telomere length test would be beneficial for the population at large. And we'll just have to see. I think these are very exciting times. We need to know these answers, and so the more patient involvement in studies like this, we could help the field move this forward and answer some questions.
Yeah, of course.
Okay. Yeah, if I may add to this, this is an issue that we're dealing with a lot in oncology too over the years. Because we have a set of genes that have been identified clearly to be inherited from parents to their children that increase the risk of developing a variety of malignancies, certainly breast cancer, prostate cancer, but it's being developed more and more. But certainly for breast cancer, it's a big issue. And now, we used to test for 2 genes, and then now we're testing for 15 different genes that increase predisposition. And the issue here includes 2 important factors in addition to what I said. Number one is that it's more than just the person who gets tested, it's the implications for the entire family, so we need to take that into consideration. Second, sometimes when we do this germline testing, looking for increased risk, we need to be prepared for how to counsel the patient and the family about what to do about it. Because that's a big issue, and in oncology, at least in breast cancer, we have some tools that can be utilized to decrease risk. And the third issue is that sometimes we do these germline tests and we find things and we don't know what they mean. We find abnormalities and they're called variants of unknown significance. And I tell you, as a lesson for all of you involved or thinking about this, sometimes that creates even more problems because we don't know what things mean, and then everybody gets so worried that there's an abnormality that they want intervention when we don't have the data to justify intervention. So that's sort of some things to think about when we consider germline testing in individuals not affected from diseases.
And there will be another session tomorrow with Janet Talbert on genetic counseling, so we can go into that in more detail. And we have a...
Greg. Sorry. Hello, Janet Talbert, genetic counselor at large.
She just flew in the door.
I specialize in IPF, as many of you know, as well as oncology, and now ocular as well. And I have one comment for Dr. Garcia's and Dr. Perez's statements. Ditto. So thank you. Just wanted to let you know I'm here. And I'll be here through tomorrow. But 3:25 today, we'll be talking about those issues, especially how they affect not just the patient. So just want to let everyone know I'm here now. Bye.
Excellent. We have time for one more question here.
Hi, my name is Heather Snyder, and I had familial pulmonary fibrosis. It's pretty aggressive in my family, and Hershey Med is doing a genetic study on that. It seems in my family, I have a lot of questions, so I'm just going to try to keep it to one statement. In my family, there seems to be a progression of the patients getting younger and younger and younger, to the point where one of my cousin's children has club fingernails at 11. And it's kind of really scary for me. So I have so many questions when it comes to the genetic field of pulmonary fibrosis. But my original question was, I had a transplant and I'm almost 9 years post-op, and I get that pulmonary fibrosis just affects my lungs, unlike cystic fibrosis where it's all through your body. So when I get a lung transplant, how do I know scientifically that I will not get pulmonary fibrosis back, especially from someone who had it familial. I don't know if it's just part of your lungs that are disformed or if it's part of the rest of your body, but how do I know? If I live long enough, I am not going to get this disease back.
Who would like to answer that? Dr. Perez has opted out.
So if I understand your question, you're asking what is my risk of getting IPF in my transplanted lungs after transplant? Okay, so for IPF, unlike some of the other lung diseases that that are treated with lung transplantation, basically, since we know that the development of pulmonary fibrosis takes several decades, in general, people do not develop IPF in the transplanted lung. And I'm sure there's case reports that are going to prove me else, that'll show things that are different than that. But in general, what we teach our fellows and residents is that you will not get pulmonary fibrosis in your transplanted lungs, just because of the complexity, and especially the time that it takes. For the genetics, we know we're born with these variants, and yet it's very rare, even in the familial. And I know you've spoken about the genetic anticipation, which is the fancy term of saying that the onset of disease can become more severe at an earlier age from successive generations. But in general, even with the genetic forms we found, it takes to the late 40s before someone develops pulmonary fibrosis. And so once transplant occurs, we're looking at a similar timeline if it was the same mechanism with circulating cells. Again, there's someone else's lung that's in your body now.
Wonderful. I'd like to close the session with a thanks to our panel. Excellent discussion this morning. For those of you that have additional questions, we now have a break, so I'd encourage you to talk amongst yourselves, as well as maybe find some of the presenters for additional questions. But a round of applause for our panelists.